topics and things that we'll go over today. So you have a patient come to the clinic with a cardiac complaint. It could be chest pain, palpitations, syncope, dyspnea, just getting short of breath. It can be a cardiac complaint. Your initial labs, troponins, X-ray, and EKG are negative. Everything comes back normal at first. What are you going to do to see why this patient's having dizziness, lightheadedness, palpitations, chest pain, whatever it is? You have to order tests to figure out what's going on. So if you're trying to assess the rhythm, they're having rhythm problems, you're going to get an ECG at first. What's the problem with the ECG? What does it tell us? Right then and then. You're doing a 6-second, 12-second, 10-second EKG. You're only measuring what's going on during those 10 to 12, 15 seconds. That's it. They may not be symptomatic at that time. The EKG is going to be normal. You want to catch these things, so you can get a Holter monitor. We'll talk about that. Or a loop recorder. These are things that are going to be recording your heart rate long term. If you're worried about the structure of the heart, is it getting thickened from long-standing high blood pressure, left ventricular hypertrophy, what's going on? You want to get echo, CT, MRI. They're going to show you the structure of the heart, how it's working. If you're worried about obstruction, coronary artery disease, do they have any blockages in their arteries? Do you want to get a cath, which is the last thing you would do, unless they're coming with emergency things. CT scan, MRI, stress test. These are things that will show obstructions. Functional capacity, how in shape is your patient? Can they still do activities? There you do a stress test. MUGAs and PET stress are also available as well. So it really depends on their symptoms. What are they coming in with? Chest pain, you got to rule out ischemia. How do you do that? Stress tests. That's how you stress the heart and see if there's any ischemia that comes about. So knowing what caused the symptoms can help you figure out which tests give you the best answers for your results. So the first thing is ambulatory ECG monitoring. It's like ECG on steroids. Basically, it's 24 hours of constant monitoring of your heart rate. So there's three main types. There's a Holter monitor, an event monitor, and an implantable loop recorder. The Holter monitor you wear for like 24 hours. That's it. It's 3 stickers you put on, they wear it for 24 hours. It's constantly recording their heart rate. The rhythm, every single beat is recorded, and it gives you an answer. Let's say you don't find anything in 24-hour Holter monitor. Then you move on to the next one, which is an event recorder. Event recorders can go on for like 3 months. You carry on like a little cell phone. And if you get palpitations, you hit a button. You know what that button does is it tags that time period. So that when you are the clinician and you're reading these Holter monitors or these event recorders, it'll tell you, hey, I was having symptoms at this time. Does my ECG show anything? And you'll look at all that stuff. So what are some indications? Okay, and then the last one is this implantable loop recorder. Basically, it's like the size of a little thumb drive, and they put it under the skin, and it's a surgery, it's a procedure, and you have that in you for like 6 months to a year. And it's, again, we're trying to catch these arrhythmias. We don't know when they're going to pop up. Okay, so implantable loop recorder can be like 6 months to 1 year, and then you just pop it out. So indications, palpitations, AFib. You want to see what their rate control is like. If they have a sort of cryptogenic stroke, they have a stroke. We don't know where the source came from. We think it's AFib, let's try and catch it. So we have to be able to catch and verify they have atrial fibrillation, and that's what these things do. Screen for PVCs, non-sustained VTach, some abnormal heart rhythms you want to make sure they're not having. Assess for silent ischemia. And as far as contraindications, there's no contraindications unless they have an allergy to the adhesive that's on the ECG pads. And even then, they do have paper-based ones that won't cause so much of the irritation. So again, Holter monitor is 24 to 48 hours. Event monitor could be weeks, and then loop recorder eventually up to 3 to 4 years. If they have a loop recorder, they usually come in and they'll see you every 3 months. They put a little wand over the device, and it downloads all the data. And then we look at it. So this is what it looks like. This is what the loop recorder looks like. Very, very, very small, about 1¼ inches long, very thin. It just goes right into the skin. And then this is your Holter monitor. You see they have just the leads on. Why do they have 4 leads, 4 stickers? Remember, one's a ground, doesn't do anything, but it's a ground. So you have to have 4 up there all the time. So this is the report. It'll give you like a little breakdown, but then this is what you're really looking for. Obviously, there's some pauses there. Here's some more pauses. So if you see this and they're complaining of lightheadedness, well, guess what? I see pauses now. You have to check that out. Here's another way of looking at it. Very fast, just eyeball, just high glance look at that. What do you see? Is the rate regular or irregular? Irregular. So you know this patient has AFib. You don't have to go any further. Look, and you can see all this irregularity right here. This can only be atrial fibrillation. And that's what we look for. They give us a printout of the entire day, and you use your eyes and you look. Okay, there's here's some issue there, here's some issue there. They're going in and out of atrial fibrillation. And now you've confirmed they have AFib, and then you can go on from there. Any questions about ambulatory ECG monitoring and what it's used for? They have palpitations, lightheadedness, dizziness. You don't know what's going on. You want to catch a rhythm. You put them on these things. Yes? Okay. Now, when it comes to insurances, this is why you have to do things in a certain order. They don't want you going right to what you need. They want you to take your steps. So you have to do a Holter first. If that's negative, then you do the event monitor. If that's negative, it doesn't show anything, then you would want to do the loop. You can't just go right for the loop recorder. You have to do the other ones first. So moving on to echo, we're looking at structure and function. There's really 2 types of echoes we're going to talk about. The first one is your transthoracic. This is your normal echo. The probe is on the outside of the chest, looking down and looking at the structure of the heart. Again, primary non-invasive imaging. You always go from the least invasive to the most invasive. Okay, this is the least invasive. It's just a probe on the chest with some jelly on there. No problem or pain to the patient. They're going to be fine. Use sound waves, ultrasound to make pictures of the heart. These are all your indications. Any type of murmur, structural problem, you want to see what's going on. The echo is the first thing you're going to do. Contraindications, none. Okay, as long as they can lay down on the bed, they can get an echo done, no problem. That's what it looks like. Now, the probe is looking at it at that direction. So if the tip of my pencil is the probe, it's right here. That's why the ventricles are the first thing that you see, are the ventricles, and then the atria, because the probe hits the ventricles first, then the atria. And that's how ultrasounds work. So it's flipped. Ventricles at the top, atria at the bottom. And the picture on the right kind of gives you your landmarks, so you can kind of see the different structures. You will not be required to read any echoes. Okay, the cardiologist will read all the echoes and they'll give the report, and then you just read the report. But this is what it looks like, and you guys will do these next summer. And here's another one with Doppler mode. So this is the left atrium that's getting filled. You can see the green and the blue is because its blood is moving in different directions. Blood is going into the atria, and then that red jet going down is going into the ventricle. So it's just movement of blood going into the atria, then back out. So when it's coming towards the probe, it can turn blue. And when it's going away, or sorry, in this case, if it's going towards the probe, it's red. If it's going away, it's blue and green because the probe is right here. That's the direction of the probe. So, but this is not going to be on your test. These are just showing you the different tests. Know what they're for. That's all. Here's another picture of looking at a different view of the heart. This is a lateral view. We're transecting the heart, cutting it in half, and so forth. But again, just looking at it, I'm not gonna be forced to know any of this stuff. So the next type is a transesophageal. Now what we're doing is we're taking a probe that has the ultrasound on it from the tip, and we put it down the esophagus, and the esophagus rides right behind the heart. So the reason for doing this is it gets better images of the heart. More clearer images, because now we are going through muscle, we're not going through skin, we're not going through bone, we're not going through air in the lungs. We're right in the esophagus and the heart is right on top. We're getting great images. So the main thing you would do a TE for, endocarditis. That's one of the big ones. You want to see if there's any vegetation growing on the valves, you want to do a TEE. That's going to give you the best images for looking at endocarditis. Also, looking at a source of embolus. We want to see if there's any clots in that left atrial appendage. That's where they like to hang out. The TEE is the way to go to visualize those clots, if they're there or not. Also, looking at any type of aortic pathology, anything going on with the aorta, the TEE is the way to go. It's closer, better image quality. Other reasons for TEE. If someone's coming in with atrial fibrillation, one of the treatments we can do is to shock their heart into a normal heart rhythm. The problem with that is that if they already have a clot in the left atrial appendage, when you put them in normal rhythm, that clot can now break free and go loose, causing a stroke. So if you plan on cardioverting someone, which is when you get them out of that irregular heartbeat, you want to check a TEE first to make sure they don't have any clots. If there's no clots there, then you are a less risk of having a stroke if you cardiovert them. So that's why TEEs are used for that. Anticoagulation, cardioversion, or ablation in patients with AFib or flutter. You want to make sure the heart structurally is okay, not having any issues, so you can cardiovert them, get them back into normal rhythm, and reduce your risk of strokes. Other indications, again, congenital heart disease, evaluate for non-coronary PCIs. Critical care setting is when it usually is going to be used a lot of. Unexplained hypotension, any complications after an MI, volume status, or any blunt chest trauma. The TE will give better results, again, because it's closer to the heart. Absolute contraindications of when you cannot do a TEE. Obviously, it has to deal with a lot with the esophagus because we have to go through the esophagus and down the esophagus to do these things. And if they have any of these problems, stricture, tumor, any history of a lack of their esophagus, don't do a TEE because you can perforate it again and cause more problems. So these are some absolute contraindications to not do a TEE. And upper GI bleed, because what if you cause more issues putting that probe down? Now I don't know, is this bleeding caused by the trauma that I caused, or was it already there? And then here's some relatives. Don't go crazy knowing all these, or any of them really, just know a lot of the big ones. The esophagus are the big ones. This is what a TEE shows. Okay, you can see that image on the right is a lot clearer than the other ones were on the ultrasounds from the transthoracic view. Okay, and here is looking at the left atrial appendage, same thing. You can kind of see a little bit there. Is that clot floating around there? Now, the next thing you do with an echocardiography is a bubble study or a contrast study. This bubble is really just agitated saline, kind of mix it up and you get a lot of bubbles in it, and then you inject that into the person. What you're seeing is if there's a septal defect where you have a communicating hole between the right ventricle and the left ventricle, if there's a defect there, a ventricular septal defect or an atrial septal defect, you'll see the bubbles go from one side to the other. They'll jump across. Because there's a communicating hole there, those bubbles will get across. That's when we do a bubble study. We want to see looking for any defects in the septum. You'll see the bubbles spread across. So again, patent foramen valve, here's your ASD and VSDs. Any vascular shunts, check. Will help, the bubble study will help determine all those things. There's also some contrast agents you can do as well with regards to echo quality, but they don't really use a whole lot of contrast when it comes to echo. The bubble study is pretty much as far as they'll go. Contraindications to the saline is none, but if they have a contrast agent, look for kidney function first, see how the kidneys are before you start giving them contrast, and so forth. Okay, any issues, questions about echo? Just know TEE and transthoracic, what's the benefits of both? And that's the best thing for right now. Stress testing, now we're looking at functional status of our cardiovascular system. as well as any coronary ischemia, looking at how well our muscles being perfused. So what are we doing? We have to challenge the heart. We have to get that heart rate up, fast heartbeats, and see what's going on. There's two ways to do it: with a treadmill, which is the normal way, or we can give them a chemical that makes their heart rate go fast and they just lay on a table. Obviously, if you have an elderly patient with bad knees and they can't walk very well on a treadmill, don't do that, because what's going to happen is they're going to tire out before you got their heart rate up to an appropriate level. The target we want to get is 85% of your max heart rate. That's the heart rate goal. And if you can't exercise long enough to get to that heart rate, then do a chemical stress test. It's just as fine. Less invasive and less expensive than cath, but is also less accurate. During a stress test, we monitor EKG and blood pressure. Test for coronary disease, specifically occlusion greater than 70% is what we're trying to capture. We learn in cardiopathophys, when do people get chest pain at rest? What does the occlusion have to be to get chest pain at rest? 90%. When do you get chest pain with exercise? That's at 50%. So what we're trying to do is we're trying to capture the people who get ischemia with exercise and see what's going on. What work rate do they start getting ischemic changes going on? And with the stress test, every 3 minutes, the speed and the grade go up on the treadmill. Or if you're on a bike, the bike gets a little harder resistance. But they're mapped out with protocols so that every stage, we know exactly how much metabolic consumption your body needs and can you meet the demands. Won't detect small blockages, and there's a chance for false positives and false negative results with a normal stress test. This is what it looks like. They're on a blood pressure cuff, they're on a treadmill, they have a little bar there for them to hold on to, and they just walk. And then you as a clinician during the test, every 3 minutes, you just ramp it up, check their heart rate, look at the EKG, and see what's going on. So diagnosing coronary artery disease, stratifying risk. Okay, if a patient needs to go for surgery, sometimes the surgeon will want cardiac to clear the patient before they go for surgery. So the cardiologist may say, let's do a stress test to make sure that your heart doesn't have any underlying heart disease that during the surgery can cause problems. Looking at patients with known coronary artery disease. Is their blockages getting worse? If it's getting worse, you're going to have more ischemic changes. If it's getting better, you'll see less, and you'll see more of the heart being perfused. Also, functional capacity. How in shape are you? How far can you go on your current exercise status? How in shape are you? Those are the things you're looking at with these tests as well, because we know how far you can walk. The further you can stay on the treadmill without me having to stop it for you, the more in shape that you are. Indications, anginal symptoms, chest pain, exertional shortness of breath. Strong risk factors, cardiac risk factors, so smoking, diabetes, hypertension, hypercholesterolemia. This is no longer a routine screening. This used to be a lot of routine screening. Now it's more like if you're coming in and you're having risk factors and chest pain, yes, we'll do it. But if you don't have any risk factors, you're not having any chest pain, there really is no reason to do stress tests on relatively healthy people. So risk factors, are they really a big deal? Yes, they are. 80-90% of patients who have clinically significant coronary artery disease, more than 95% of anyone who experienced a fatal coronary heart disease event had at least one of the major cardiac risk factors. Okay, 95% had at least one of them. Okay, new major risk factors, C-reactive protein. What is that going to tell us? Inflammation. Fibrinogen. What's that going to tell us? Clotting. Remember, obstruction is developed via a clot and clotting mechanisms. So if we have high fibrinogen, we could be high risk for clots leading to ischemia and obstruction. Lipoprotein little a and your homocysteine, again, markers of inflammation. And lipoprotein little a has to do with LDLs. Contraindications, the absolute ones, anything acute, makes sense. If they're having acute symptoms, you don't want to stress them. You may cause a full-on heart attack if you do decide to stress them out. So anything acute, don't do anything with a stress test. It's fine. So there's many types of stress tests available. The first one is a plain treadmill stress test, also known as a gated exercise stress test. This person just jumps on a treadmill, has the EKGs on them, and does their 10 to 12 minute exercise, and then they're done. There is no imaging going on. It's just looking at EKG changes. If we see ischemia, which way is that ST segment depression going to go? Down or up? Ischemia is down, infarction is up. Okay, so if you start seeing changes on their EKG, you start seeing ST depression, you're causing ischemia to occur. And if it continues on, if you keep them on that treadmill, you don't get them off, you'll start seeing their ST segments creep up, and then they go positive, and then you're like, oh my God, what am I doing to this patient? So watch out for those ST segments. Stress echo. Okay, this is a lot of what I do with the basketball stuff when I do the stress echoes. Low risk, but need more information about cardiac wall motion. Okay, wall motion abnormalities. Is their left ventricle squeezing right? You want to stress them out. Look at the wall motion on the echo. So as soon as they're done with their treadmill, they have to jump immediately onto a table and lay down, and the ultrasound technician will do the extra scan on them and see how their heart wall motion's doing. Myocardial perfusion scan. This uses radionucleotides. Not radionucleotides. Radionuclear medicine, radioisotopes. The first one is this technetium is a big one. We draw your blood, we add technetium, 99 TCM to your blood, we infuse it back into your body. And we see where this blood goes, and if it perfuses everything, you see the heart glow. And I'll show you some pictures of that, and you'll see how ischemia forms from there. They also have some other ones with PET scans, which show some functional MRIs to see how well the heart is working with oxygen uptake when they are under this stressful environment. Can be performed with or without the treadmill because you just give them chemicals. Pharmacologic stress test, this is when you give chemicals to raise their heartbeat because they can't do it themselves. They can't get on a treadmill because they're too weak. They're not going to be able to get their heart rate up. So there's also one, a dobutamine stress test. Give dobutamine is the agent to get their heart rate up. Other ones you can give dipyrimidol, adenosine. Don't worry about memorizing these. You don't have to worry. Just know there are other ones out there. They all do the same thing. They tag the blood, and we see where this blood goes, looking at it under a camera, and we see how it glows. Protocols, everything has to be based off of a protocol. You can't just do a stress test and be like, I want to do this speed and grade and see what happens. No, you have to follow the protocols. There's different ones. There's Bruce, modified Bruce, athletic RAM, Naughton. Basically, the job is this. We want to get your heart rate up in a constant way. So every 3 minutes, speed in the grade gets faster and steeper, and you just work, you keep going until your heart rate hits the magic number, and then we stop. When to avoid treadmill. If they can't exercise due to leg claudication, arthritis, deconditioning, pulmonary disease, these people can't walk on a treadmill, don't put them on a treadmill stress test. Their heart rate will never get as high as you need it to see changes. So do a chemical one. Any patient with ECG changes at rest can also interfere with the test. So when a stress test goes on, there's two things that are going on. We have the imaging and we have the ECG tracings. Okay, ECG interpretation, looking for any arrhythmias. Did anything pop up that was new when they were exercising and stressing themselves out? Any ST segment changes, whether it's down or up? Do they show any ischemia, or do we have any actually damage with infarction? Image interpretation, looking at wall motion. How is the wall contracted? How is the left ventricle wall? Is it squeezing appropriately? If not, that means there's underlying damage to the heart because it's not squeezing the way it's supposed to. Perfusion is the big one. Where is this blood going? Are all the arteries that feed the heart, are they all patent? Is there enough blood getting through? So stress test interpretation, ST segment depression. If you see upsloping, that's okay on a stress test. An upsloping ST segment is a normal finding in a stress test at high heart rates. Okay, a downsloping or a horizontal is not good. You see downsloping ST segments or a horizontal ST segment depression, that is clinical ischemia. Whereas an upsloping is just due to a fast heart rate. And it's okay. It's not pathological for anything. So upsloping is okay, downsloping is no, horizontal is no. You don't want to see these changes. Limitations. If they have an underlying left bundle or a V-pace rhythm, you cannot do a stress test. Yes?
When they're having the ischemia on the stress test, are they normally pain-free or are they normally like...
Depends. We want to know when does there, remember with, bless you, with exertional chest pain, it's always at a same workload where you start getting ischemic changes. So we want to see where that workload is and you start seeing ischemic changes. Whether or not they have pain may happen a little bit later, but we're already seeing those changes due to ischemia now. I would stop this test to be like, okay, let's rest and go down. Let's not do anything. If they have an underlying left bundle, you can't do it because you can't see any ST changes. If they have WPW, you can't do it. Remember, what is WPW? I know it's Wolff-Parkinson's white. What is the ECG finding with Wolff-Parkinson? The delta wave. It's a sluggish wave. It's going to alter the QRS complex. If they already have 1 millimeter ST depression at rest, don't stress them because you don't know what's going on with that. Okay. If they have any DIGUS with ST wave abnormalities or left ventricular hypertrophy with ST wave changes, remember with left ventricular hypertrophy, they can get T wave strain where the T wave flips. If you see a flipped T wave, don't stress them because the EKG will not show you anything worthwhile. Hypokalemia, okay, that alters your T wave. That's going to mess up how the ST segment looks. So here's a patient who did a stress test. At rest, we're okay. Stage 1, still baseline. Now we start getting some upsloping ST waves, ST segments. Does everyone see that upsloping this ST segment right there? You see how it's upsloping, and even stage 2, still upsloping. We're okay. Now, we have them stop, recovery. Okay, we let them rest. We see how they do after they start work, after they finish. Look at the ST segment. What's happening? We're getting horizontal. It's starting to flatten out. Does everyone see how that T wave, it went from an upsloping and now it's starting to flatten out? Okay, they're getting some R pain there. Then we gave nitro because they're having ischemic changes, right? Look at this. Now we got downsloping. I told you downsloping is bad. Okay, so this is an example of what can happen with a stress test. You can see how those ST segment changes. First it was upsloping, that's okay. Then they started getting some chest pain, and that turned into full-on ischemia. Okay. Okay, nuclear imaging. Is the blood getting to the tissue? If not, that means there's blockages somewhere. So what we're going to look at is donuts and horseshoes. When we look at the images, you're going to see, look at donuts and horseshoes. Okay, so you see horseshoes and you have donuts. The donuts are taking the ventricle. Since I have a heart here. The donuts are taking the left ventricle and slicing it this way. So we have the hole, and we're looking at it across. These are the donuts. We're slicing it this way. Okay? The horseshoes is slicing it this way. So now we have the arch of the left ventricle this way. We slice it this way. This is the horseshoes. This is the donuts. And by slicing up the heart all this way, we can see every muscle going up and make sure they're all being perfused. On this picture, you see this is rest. So we take images before we even stress them. So that whole row is just what the resting images show. These are the stress. Rest, stress, rest, stress. You want to compare those images. Do you see how they look relatively the same? Rest and stress. This is a clean heart. There's no blockages there because the rest images and the stress images are the same. So the heart is being perfused good. There's no problems with the perfusion of the heart. Now let's look at this one. Stress, rest. Look what happens there. You see how you're missing that little piece right there. It was perfused here at rest, but now you don't see the bright orange anymore. This means that during the stress period, that's where the ischemia was. And this is how cardiologists can tell what vessel is the culprit based off of these images. You don't need to know what this interpretation is, but you're visually looking at this, where you can look at this, it's like, okay, they have blockages right there. Here they don't have it at rest, but with stress they have it. You can see even here, pieces that are missing. Look at this part. This whole piece is missing compared to those ones. This is coronary artery disease that you're picturing now with nuclear imaging during a stress test. And that's why we do stress test. Everyone good with that one? Okay, here's it. This is a SPECT, which is the nuclear versus PET scan. You can see how much more image quality we get from that PET, that functional imaging, than we do with stress. We don't do PET because it's very expensive. So stress tests are easy. All the cardiologists have it in their office. They can do nuclear stress testing much easier. If you suspect any problems, then you can go on to the more specific testing like the PET. Or this patient would probably go right to a cath because you've seen demonstrable ischemic changes. They're not being perfused with exercise. Other types of cardiac imaging, here's our PET scan. Again, measuring metabolic and perfusion rate within the heart. How functionally active is that muscle in the heart? Can pinpoint areas of blockage or impairment, so we know exactly where they are. Particularly important with patients with history of MI and if they're looking for revascularization. So if they're going for bypass surgery, stenting, you may want to get a PET to make sure that is that tissue even viable. If I want to bypass and reperfuse this tissue, is it even metabolically active? Is it alive? Can it be perfused and do a function? If it's not, why would I put blood supply into an area of the heart that's not going to work anymore? So the PET will tell you that. Also can aid with people with myocardial viability, what I just talked about. Is the heart even able to get blood? Also looking at myocardial perfusion. And again, same thing, you're looking for areas of lack of perfusion. They don't glow as much because they're not getting blood supply. Remember, all those red blood cells are tagged with a nuclear isotope, so when they put them on a camera, it's going to glow wherever that blood perfused. We're getting lack of supply, lack of a glow, there's ischemia there. A MUGA scan, multiple gated acquisition, is basically looking at LV function. What's your ejection fraction? That's all it's going to do. It is nuclear as well. We're looking at how much goes into the heart, how much leaves. We're able to better calculate it with a MUGA scan than we are with a regular echocardiogram looking at the ejection fraction. These are good for patients who are undergoing or will be undergoing chemotherapy or radiation. Some of these drugs that we give for chemo are very toxic to the heart. So we want to see how the heart is doing before we even start any of this stuff. That's what a MUGA is for. It's just going to tell me left ventricular function. Indications, again, chemo, cardiotoxic therapy, and looking at ejection fraction. Those are the biggest things. Okay, cardiac catheterization, structure and obstruction. There's therapeutic caths and there's diagnostic catheterizations as well. So indications for revascularization, where is the stenosis? Where is the blockage occurring? We inject the contrast dye, and we look under the camera, and you see all the vessels. How is their hemodynamic response? How is their pressure, oxygen levels? With this cardiac catheterization, we can detect pressures inside the heart. They have pressure sensors in there as well. Ventriculogram, if we wanted to look at right ejection fraction, okay, you need to access the heart from the other side. Biopsies, defects, heart valves, ablation, ligate, that left atrial appendage. We mentioned that clots like to hang out in there. Well, we can do a procedure that basically walls off that left atrial appendage so that whatever's inside there can't get out and nothing new can get in there. Contraindications, patient refusal is really the only one with a cardiac catheterization. Relative electrolyte abnormalities, renal failure are your big ones because you have to get rid of that contrast agent. We have to get rid of it, metabolize it. The kidneys is what use it, that does a lot of it. So watch kidney function before you give them that stuff. Any allergy to that contrast agent. Depending on how bad they need this catheterization, you can pre-medicate them with some Benadryl and some fluids to help alleviate any of those allergy responses from that. Pregnancy, because you can't give contrast dye to a pregnant woman. Relatively safe procedure, deaths, MI, CVAs, 1 in 1,000. Excess site complications is the more common problem. Okay, you're putting a needle in your groin to get access to your femoral artery, essentially. Okay, that's under a lot of pressure, so when they're done, you have to hold a lot of pressure to that site to make sure there's no hematoma forming. So access site complications. They can also do it through the arm, through the radial artery. They can do caths through there as well. Those are the two access points we use. Contrast-induced nephropathy. This is giving contrast agent to people with kidney problems, and you cause more kidney damage with all the contrast. So this is where the catheterization goes. It ends right there. Why does it end right there? Why doesn't it go into the ventricle? What are we testing when we do a cardiac catheterization? What are we looking at? We're looking at the coronary vessels, right? Where do the coronary vessels branch off? In the aorta, right around here. So we leave the catheter right there, so when we inject it, the right and the left coronary arteries are both getting the contrast dye. And we look and see what happens to the vessels. Okay, this is what it looks like. Okay, there's already been labeled, so you know the left LAD is up top, the circumflex coming around here because of the way that the camera is on these fluoroscopies when you go for the catheters. Okay, here's an aerial look. You can see all that good stuff, all those vessels. Now, there is the thrombus. Do you see? We're squirting and nothing is going through. Do you see how that blockage is happening? This person's not getting any perfusion at all in the ventricles because of the blockages that are going on. So this is what happens before and after cardiac catheterization. Do you see how this little pinch right here? Let me try and circle it when it comes back. Here it is. That is a stenosis. Okay, just if you don't miss it the first time, wait until it pops back in the red. And then look on the right. You see how it all opened up? We get great perfusion through the whole entire vasculature. This is what a cardiac catheterization does. They blast open the thrombus, makes the artery patent again, and blood goes through it. The next one is a CT angiography, looking at structure and obstruction as well. This is your CT scan, CT angio, looking at those calcium scores. Direct visualization of coronary blockage without invasive testing. Indications, strong clinical suspicion conflicting with the stress test. You did a stress test, didn't show anything, but you're like, I think they really do have some underlying disease going on. Let's do a CTA and see what's going on with the vessels. If they're having symptoms, intermediate risk for coronary disease, do a CTA. If they have ECG changes, you don't know if this is ischemia or not, do a CTA. If they can't exercise and stress tests aren't really meaning anything. Great option if you're trying to avoid cathing your patient. You can do these CTAs. Contraindications, contrast, because we are giving them contrast dye. Beta blockers, low pre-test probability of CAD, or a high likelihood of CAD. Don't bother with a CTA, just get a more sensitive test. Go to your invasive testing. Radiation exposure, again, this is a CT scan. Are they getting a lot of CTs? You may want to back off on all this imaging with all this radiation. And any prior stents that can cause image artifact. So if they have a stent already, don't do a CTA. This is what it shows you when it's done, again, looking at the heart and all the vessels. I don't know why it's going so fast, but you get the idea. That's what a CTA shows. So one of the things that the coronary CT will give you is a calcium score. Okay, if you have greater than 100 in a single vessel, it's positive, or greater than 400 units, it'll be a score on the CTA. You're not calculating anything yourself. You're going to get the report, and it'll tell you. This is not foolproof. They can have soft, non-calcified plaque still. Also, the problem with CT, you don't know if the calcium is in the artery itself or is it causing plaque inside the vessel. You don't know where the blockage is because it's calcium. If you have a calcific hardened arteries, it will show up white because it's calcium, it's white. So that's what you're looking for is a calcium score. You can also do cardiac MRI. Again, looking at structure and function. If the patient can't do the CTA, you can do a cardiac MRI. We don't use them very often, cardiac MRIs. There's got to be some sort of underlying structural problem, congenital problem that you would do a cardiac MRI. Worried about cancer in the coronary system, you would get a cardiac MRI. Not for detecting coronary stenosis, okay? But looking at structural defects. Congenital anomalies, coronary artery aneurysms, those structural changes, cardiac MRI is very good. Better for imaging CABG stenosis, so sometimes you get a bypass. Those can stenose, the bypasses can clog up too. That happens, so you can do that. Contraindications, implanted medical devices. Iron in the eye, because again, you're going through an MRI, the very, very high magnets. You don't want to get it pulled out. And obviously claustrophobia. Are they even able to tolerate the MRIs? MRIs take longer than CT scans do. If you ever had an MRI, you're in there for like 45 minutes. If it's a closed MRI, it can get very claustrophobic, a lot of banging, people don't like it. So it's a relative contraindication. And this is what it looks like with a cardiac MRI. And more images of what the cardiac MRI, again, more structural stuff, nothing with blood flow as far as ischemic changes or whatnot, but it gives us a good idea of what the structure is like, any aortic problems and so forth. Now, this last thing is talking about sensitivity and specificity. What is sensitivity talking about? Can it pick up a disease or not? Is it sensitive? Exercise ECG is only 40 to 50% sensitive to coronary artery disease. However, look at the specificity. That means if you got a positive result, 90% of the time that is a true positive result. So if you had real ECG changes on a stress test, very high likelihood that you really do have coronary artery disease because of very high specificity. Look at coronary CTA. Coronary CTA is very sensitive to picking up calcium and those changes in the cardiac system. However, if you even are positive, is it very specific for that? Not very. So Dr. Wood will go over all this with you guys as well in EpiBio, you learn about this stuff, but sensitivity and specificity are very important when you're looking at tests that you want to order. Why are you ordering this? Because it's very sensitive and specific for coronary artery disease. And we are done. Okay, take a 5-minute break, come back at 3:15. Yeah, about 7-8 minutes, 3:15, and we'll do our review.